Thank you very much. Welcome, everybody. I'm Shaba Jaffer. I'm the director of the Institute for Global Health. It's really nice to see you all. Really nice to see Tim's family and friends and kids as well. You're all really welcome here. Tim is, sorry, he's got quite a long title, so I have to be careful I don't miss out a word. So Tim is Professor of Global Health Systems, Epidemiology and Evaluation. He basically did a BSc in microbiology in 2003, and he's been with us since then, pretty much, apart from about a year studying in the London School. So he's been with us right from the start, and he's had a very meteoric rise in a fairly short period of time. He's had a very fascinating life in his work. He's lived in Malawi for 4 years, where actually I met him once. I bumped into him there in somebody's house, and travelled all across Africa. We're very much looking forward to his talk today, which is called Lusaka, Lilongwe, London, Lagos, Journeys in Epidemiology, Health Systems Research and Evaluating Interventions. So Tim, I'll hand over to you. We're very much looking forward to your talk.
Thanks so much, Shaba, and good evening, everyone. Thanks so much for coming. It really means a lot. And hello to everyone watching online. Thanks so much for joining. It's really great to be here, and I'm looking forward to telling you all about my work as Professor of Global Health Systems, Epidemiology and Evaluation at UCL Institute for Global Health, IGH. And it's good to see many colleagues from IGH here in the audience. And I'm also going to tell you about the story of how I got here. As I'll explain, my work broadly focuses on evaluation of health systems interventions to improve maternal, newborn and child health in places with high mortality and morbidity. My talk's divided into 3 parts. First, I'll give an overview of the work I do now. Then I'll take you on a journey of how I got here, including the highs, lows and notable events in my career to date. And then I'll finish with what I hope to do in the coming years, including some upcoming things to watch out for. So as my overly long job title indicates, I have 3 main areas of work: health systems research, epidemiology, and evaluating interventions. I'm going to talk about the highlights of my current work in each of these 3 areas before diving into how I got to be doing these things. The first area is health systems research, understanding how health systems work to produce high-quality healthcare and improve health outcomes. I have 2 large projects in this space: Quality of Care Network, QCN Evaluation, which is primarily qualitative, using interviews, surveys, observations, and document reviews, and Thanzi La Onse, which is ongoing through the Thanzi La Mawa project and is primarily quantitative, using mathematical modelling of the whole health system of Malawi. First, QCN Evaluation. The full title of this grant is How Does a Multi-Country, Multilateral Network Focused on Specific Healthcare Improvements Evolve, and What Shapes Its Ability to Achieve Its Goals? We evaluated the World Health Organization Coordinated Network for Improving Quality of Care for Maternal, Newborn and Child Health, that's the QCN, which includes 9 countries in Africa and 2 in South Asia. Our evaluation focused on 4 case study countries: Bangladesh, Ethiopia, Malawi, and Uganda. This photo shows one of the highlights of my career to date, last March in Ghana. After presenting our findings to representatives from 11 ministries of health and partners, I was invited on stage by the WHO Secretariat and network leaders to discuss, for over an hour, the results of our research in relation to the planned next phases of the network. See, that's me on the stage there. At this stage in March, we only had 7 not yet peer-reviewed preprints from our total of 9 planned papers, but our findings help guide discussions and plans for the next phase of the network. This study has a lot of different components, and unfortunately I don't have time to present the background and findings, but I've got a long deck of slides if anyone's interested. But we do hope to do a full dissemination event, potentially online, later this year when our whole collection of papers and associated commentaries is out. But I'll just say briefly that we were able to explore how the network operated at global, national and local levels, enablers and barriers to such processes, and how and why the network was able to emerge more strongly and be more effective in some countries and settings and less so in others. I want to highlight here on this slide that this research is the work of a brilliant team of 31 people across 8 institutions and 7 countries who've been working on this over the past 5 years. We worked together to write a series of 9 papers for PLOS Global Public Health, 4 of which have been published so far. They're the ones with titles in bold, with others as preprints. Though we just received the good news 2 days ago that paper 3, which is one of our main ones, has passed peer review and has been accepted for publication. So that should be coming out in a few weeks. In many ways, we created a network of researchers to do this work evaluating the quality of care network. Each of our papers has a different early career researcher from our team as first author from across all of the institutions and case study countries involved. Don't worry, I'm not actually going to read this slide. I've just got it as a reference in case anyone wanted to look up any of the papers. Moving on to the other main health systems research project I'm working on, this one is highly quantitative, so quite different to the QCN evaluation. It's also a large collaboration led by Prof Tim Hallett at Imperial with investigators and researchers at Kamuzu University of Health Sciences in Malawi, which the model is focused on, Imperial, UCL and York, and a partnership with the Eastern, Central and Southern Africa Health Community, through which we hope to develop the model for other countries in the region too. Thanzi La Onse means health of all in Chichewa, the most widely spoken language in Malawi. This is an ambitious whole health system, all diseases. We currently have an estimated 85% of the disease burden represented, whole life course, individual-based mathematical model that we hope will inform priorities for coming iterations of the Malawi government's 2023 to 2030 Health Sector Strategic Plan 3. Please check out the website. And if you're keen, the repository is now open source on GitHub too, as per the link at the bottom of this picture here on the website. The model is coded in Python. My work on the TLO model focuses on reproductive, maternal, neonatal and child health components, together with Joe Collins, Inez Lin, Eva Januszkova and many others. Many of our Thanzi La Onse model papers should come out this year, and this one on contraception, which I led, came out just before Christmas. We hope this work will be useful for colleagues in the government of Malawi and eventually other countries when considering contraception scale-up options, and likewise that the other module-specific papers, for example, the ones on HIV and TB, malaria, pneumonia, maternal, perinatal and newborn health, and the main overall health systems model paper should be useful too. Via the follow-on Thanzi La Mawa Health of Tomorrow project, which runs to 2026, we hope to also make this model available to translation to other countries in the region, as I mentioned. Just to say, we're also collecting new data to fill gaps in our model, including a detailed time and motion study of health worker activity minute by minute. And I've just come back from the training of data collectors for this in Malawi, which was held last week, and piloting is ongoing this week. Moving on to epidemiology, in many ways my epidemiology work links my work on health systems, such as the work you've just heard about, and my work on evaluating interventions, which I'll come on to next. Most of my work focuses on understanding health and disease and how to improve health outcomes for mothers, newborns and children in contexts where morbidity and mortality is highest. My main current work evaluating interventions is our research evaluating the Save the Children Nigeria One Inspiring project on childhood pneumonia and infectious diseases in Lagos and Jigawa states in Nigeria, which we're just finishing after 5 years. Our final results papers are currently under review, so hopefully should be out this year. I think I can say that given we're still in January. This is joint work with Professor Falade, Dr. Bakare and Dr. Ichendu from University College Hospital Ibadan, Dr. Karina King from Karolinska Institute, Dr. Hamish Graham from MCRI in Melbourne, Dr. Eric McCollum from Johns Hopkins University, and Dr. Rochelle Burgess from IGH, together with our excellent research team, Agnese from Malayo, Tayo, Julius, and Damola. The Inspiring Jigawa study is a cluster randomized trial of a complex intervention to build capacity of communities and healthcare providers in Kiawa local government area on pediatric pneumonia. This was done through 3 intervention components: men's and women's community groups, healthcare worker training on integrated management of childhood illness, IMCI, and a community facility link group for mutual accountability. The primary outcome of this study is all-cause under 5 mortality. The Inspiring Lagos study is a pre-post impact and process evaluation of an integrated training and mentorship approach to the introduction of pulse oximetry and enhanced sustainable oxygen systems in outpatient care in Ikorodu local government area in Lagos State, Nigeria. The primary outcome of this study is a case fatality rate of pediatric pneumonia in children under 5. Much of my other work also evaluates interventions, including evaluation of the quality of care network I just talked about, and many maternal, perinatal, and child health interventions via the TLO model. And as some of you know, I also teach evaluating interventions to our master students in a module I designed and started 10 years ago now. And together with James Hargreaves at LSHTM, who runs a similar course, we're also at the start of writing a textbook on this. And I'll come back to this in the last part of my talk. So, how did I get here? I'm going to start just over a quarter of a century ago when I was deciding what to do at university. This was around the time that I radically changed my hairstyle and was probably at the peak of my football ability, setting my keepy-uppy record of 24. My mates from football wouldn't believe that now. But I was interested in health and did consider medicine, but thought that would be a too difficult life with long hours and stress. But what did I know then, though? So I chose biology at UCL in the end, but soon realized I wanted to do something more related to health, so switched to microbiology in my second year, which I enjoyed, including 2 3-month lab projects, including a summer internship in my hometown Southampton in Prof Tim Elliott's Cancer Research Lab, looking at using the immune system to fight cancer, and my undergraduate dissertation work improving the sensitivity of an HIV test in UCL labs. I realized I didn't want to spend my life in the lab, though, and thought I could do much more to improve people's health outside of laboratories. So I got interested in public and global health, often called international health in those days. And in 2002, one day, after one of my lectures here, I walked past this building and crossed the road to LSHTM, the London School of Hygiene and Tropical Medicine. And I sat there in the library for hours browsing books and journals. I remember then thinking, this is what I really want to do. Work to improve population health for populations with the greatest need. Though then wasn't sure how best I could do that, whether working for an NGO, government, international agencies, or in research and academia, I really wasn't sure. I looked up the LSHTM master's courses and thought the one on control of infectious diseases was the one for me. And fortunately got into that based on my first-class undergraduate degree, despite limited work experience. My time at LSHTM from 2003 to 2004 was really foundational in that I learnt just as much from my fellow students who had a wealth of knowledge and experience from all over the world, as I did from the lecturers and professors there. I'd like to also give thanks to my late grandfather, Brian Crozier here, who funded my master's study. Without his generous support, I wouldn't have been able to do this course and may have ended up somewhere different today. My time at LSHTM also provided me with lots of opportunities, including my dissertation work on integration of TB and HIV services in Lusaka, Zambia. Although I only spent 6 weeks there, and actually only got a 59, not even a merit on my dissertation in the end, it was a really immersive and transformational experience for me. I was fortunate to be hosted by a Zambian family who were friends of my supervisor, Dr. now Professor Helen Ailes. The head of the family, Jeannie Malenga's life had been saved via being given antiretroviral drugs through the Zambart project I was working with. And in addition to her teenage children, had taken 3 younger orphan street children into her house where I was staying. When I visited again 6 years later on my way to the World Cup in South Africa by road, I was amazed to find over 20 kids in her house. She's really an inspiring person. I spent as much time in Lusaka as I could, talking to people, visiting and exploring places with colleagues and their friends from the project and related projects, going to the townships where my supervisor had been known to ride her horse, going out to shows and clubs. It really brought home to me just how different people's life chances and health can be, based purely on the place they happen to be born into, and got me even more focused on trying to work towards tackling some of the many risks to health and well-being. So I was all set for a career in global public health and started applying for jobs when I got back from Lusaka in August 2004, just over a month before I finished my master's. However, this wasn't to prove easy. I think I averaged about an application a week, and 39 applications, and 9 months later, I finally got a job doing something I wanted to do. In the meantime, I was doing traffic, parking, and bus surveys like this. So my first pearl of wisdom is from this time. Be tenacious, shrug off disappointments, and keep going. This has also proved useful in my career. For example, from 2014, I kept submitting grant applications as principal investigator. And after 13 straight rejections, I landed my 14th, 15th, and 16th applications in 2018 and 2019. Thanks so much to Professor Ruth Gilbert, who hired me for my first research job. This was on prevention and treatment strategies for Group B streptococcus early and late onset neonatal sepsis in the NHS. And unlike my master's dissertation, I think I did a good job of this, including a 32-question systematic review, input across many areas of the work, and 3 first author publications, including a long health technology assessment report, which was used in Royal College and Obstetricians and Gynecologists guidelines on Group B strep. This project was a really great introduction to research for me, spanning health services research, epidemiology, and health economics, and showed me what these disciplines and mathematical and statistical modelling could do to inform policy, things that I'm still very much focused on. However, despite this early research to policy success, this first job was time limited, only about 20 months, and was also not exactly what I wanted to do, in that it was focused on the UK rather than other places that had much higher mortality, such as Malawi. So I started searching for work abroad and fortunately got a job, also with UCL, based in the Centre for International Health and Development, a precursor to the Institute for Global Health, 2 floors below where I was in the Institute of Child Health building in Guildford Street, but based in Lilongwe. So whilst in some ways I've just travelled across the road, across Russell Square, and then down the stairs, these movements were also connected to far better places to be, like Lusaka and Lilongwe. How I came to Malawi was initially down to bad luck, though. A horrible car accident involving the UCL and Maimwana research team during their work on the maternal and newborn health in Machinji district. Fortunately, no one died, but there were some severe injuries. I got a temporary post as a research assistant to cover Sonia Lewiska while she recovered. Then, whilst I was there, another project was starting up in Lilongwe, Kasungu and Salima districts. So my post was extended from 3 months to 2 years to focus on this new work of the Maikanda project, which then became 4 and then 5 years, nearly all of which I spent living and working in Malawi. So whilst the circumstances that resulted in my getting a job in Malawi were initially bad, I like to think I came to stay there by working myself into a job. In my early work evaluating the Maikanda project, I noticed a gap in the technical skills on impact evaluation and economic evaluation in the team on the ground, so I worked hard to learn these methods as best I could and ended up leading the analyses and writing up of both the main cluster randomized controlled trial, which found a 16% reduction in perinatal mortality resulting from the community women's group intervention and a 22% reduction in neonatal mortality resulting from the women's group and health facility-based quality improvement intervention combined. And the economic evaluation, which found both to be cost-effective, as well as the 365-page Maikanda final evaluation report, which explains these effects and more. I also got the opportunity to undertake my PhD in health economics part-time while I was there on quality of life and methods for investigating it in relation to the Participatory Learning and Action Women's Group Community Mobilization Intervention. So I lived and worked in Malawi most of the time from 2007 to 2011, sometimes working 70 hours or more a week, sometimes going to the Lake of Stars Festival or taking a 4-week road trip to the World Cup all around South Africa and back. So I'd like to pause here and do some thank yous. First to my mum, dad, twin brother Greg and sister Chrissy for their encouragement and support and fun times. Great to see you all here tonight too. Here we all are on Zomba Plateau in Malawi when you all came to visit me for a month in 2008. And to Bijoy, Mahima, Nimai and Neil for providing me a home away from home for my first 6 months in Malawi in 2007. I know you're all watching online. Thanks so much for your friendship, hospitality, and many fun times together too. It was great to catch up with Mahima and Neil in Lilongwe last week too. Neil is now 17. He's the baby there, he's now 17. It's amazing how time flies. I'd also like to stop here and thank a number of outstanding people individually who've been instrumental to my professional journey. Firstly, my dear friend and colleague, Dr. Bijoy Nambia, who not only provided me a home with his family for the first 6 months we were both in Lilongwe, but also for his great collaboration as a close colleague for 12 years at UCL before he moved on to UNICEF Malawi and now WHO Ethiopia. I'd also like to thank my mentors and supervisors, including Dr. Charles Mwansambo and Dr. Peter Kazembe. Peter sadly passed away in 2020, though it's great to see Charles still involved in many things even after his retirement last year from his service as Chief of Health Services of the Ministry of Health of Malawi. I still remember early work from your offices at the bustling Kamuzu Central Hospital in Lilongwe. Charles was head of paediatrics in the hospital back then in 2007, and Baylor College, and from Baylor College in Lilongwe as well, which Peter headed up. And my old boss when I started in Malawi in 2007 to when he left UCL for the WHO in 2015, Professor Anthony Costello. I'd like to thank Anthony for hiring me and for his support and backing of me both in our work in Malawi and in getting a lectureship at IGH in 2013, and for involving me in many other research collaborations over the years. And my PhD supervisors, Professor Jolene Scordis and Dr. Shepley Orr, thanks for being great supervisors and seeing me through with no corrections to my thesis after my viva. As many of you may know, Jolene is still at IGH doing lots of great work. Shepley sadly died young in 2018, losing a battle to alcohol addiction, something I wasn't really aware of during my PhD while he was still holding it together and doing good work. And Professor David Oswin for his support as my appraiser after Anthony and Jolene, and for getting me into teaching, as well as numerous interesting research collaborations. and my current appraiser and also a long-standing colleague, Professor Audrey Prost, who's helped me navigate my way forward, especially in recent years. And Professor Ibrahim Abubakar for supporting my professorship bid and for being a great director of IGH and now the faculty, as well as for involving me in the Lancet Nigeria Commission, which I'll talk about a bit later. And on this slide, I'd also like to thank Gibson Masache and Charles Makwenda. Gibson was the original director of the Parent and Child Health Initiative, PACHI, a research-focused NGO who our team at UCL have worked with closely in Malawi since it started in 2008. Gibson sadly passed away a few months ago, also far too young. Charles Makwenda took over from Gibson in 2015 and currently leads PACHI. I wish I had more time to thank the many other colleagues I've worked with and continue to work with, though I will show names at the end. There are too many people to talk about in this short presentation. I'd also, yeah, there you are. I'd also like to thank my amazing family. Just 3 weeks after I passed my PhD viva in 2012, I met my wonderful life partner, Catherine. 3.5 years later, we had Chloe, and another 3.75 years later, we had Layla. Thank you for all your love, support, great times, inspiration, and joy, and for being here tonight as well. Before I finished my work on the MyCanda trial and my PhD, in 2011, I was fortunate to get involved with 3 other projects in Malawi as a co-investigator, which all ran concurrently from 2011 to 2016. I'll talk about each in turn over this slide and the next 2. The first on this slide was a Gates-funded evaluation of the PCV13 vaccine for childhood pneumonia, the start of my work on childhood pneumonia, which is still going strong. I'll come back to this in a few slides. We, and I'd like to thank the whole team here, measured pneumonia cases by severity and hospital mortality over 2.5 years at community, primary healthcare and hospital levels, covering a population of hundreds of thousands of people. We found that 76% 3-dose coverage of the PCV13 vaccine was associated with a 47% reduction in hypoxemic pneumonia, a serious form of pneumonia where blood oxygen saturation is below 90%, and a 36% reduction in hospital mortality. We also found, perhaps unexpectedly, that the incidence of the least serious fast-breathing form of pneumonia significantly more than doubled. However, this fits with bacterial pneumonia targeted by the vaccine, reducing, including in cases where there is viral and bacterial co-infection, to leave more viral-only cases, which can be less severe, as well as viral pneumonia potentially moving into the gap left by less bacterial pneumonia. I'd also like to highlight here that this project was very much a learning experience for me. I got stuck on the time series regression analysis and was helped to complete it by one of the greats in this area, Professor Ben Armstrong, and I now teach time series regression at UCL, using this study as an example. The second of my 2011 to 2016 studies as a co-investigator was an EU-funded project called Missed Opportunities in Mother and Infant Health, MOMI, looking at integration of postpartum services for mothers and infants, that's services after birth. This was a realist evaluation across 4 countries, Burkina Faso, Kenya, Malawi, and Mozambique, where we looked at how and why adding the resources of the MOMI interventions in different contexts resulted in different effects in terms of provider and recipient behaviours and health outcomes. Our main findings were that in settings where the intervention package worked best, community health workers were able to create a buzz around the need for postpartum care and act as a bridge between the community and the health facility, resulting in increased access to postpartum care, and that systems of accountability need to be in place to improve the delivery of postpartum care, which was often overlooked compared to other areas of care. We also found that mother and infant postpartum services and clinics were more easily integrated together in smaller less complex health facilities. As with all of my work, I'd like to thank all involved, and I'd also like to give special thanks here to Nella Jaluli for her immense contributions to our MOMI research in a relatively short time, as well as all her work on the QCN evaluation you heard about earlier. Nella also explained the study to the World Health Organization as part of an expert meeting on postpartum care, enabling the work to have an impact on policy. The third of these three initial co-investigator studies was Evidence for Action, which was a multi-country 5-year project focused on getting evidence into policy making and improving the quality of care for mothers and newborns, including a public campaign called Mama Yay. This was a large project across 6 countries: Ethiopia, Ghana, Nigeria, Malawi, Sierra Leone, and Tanzania, with my work on it focused on Malawi. The idea behind this work was that a combination of evidence and focused advocacy could lead to greater accountability through better use of evidence and higher political will, that accordingly decision makers could make more efficient and effective use of resources, which will in turn improve the quality and availability of healthcare for women and babies. Some examples of this work include scorecards and dashboards for staff and members of the public, like the dashboard shown at the bottom left here, to promote a culture of partnership and accountability, both for the supply side, the health facility, and the demand side, the community, that together should lead to action to improve the quality of care. And community-linked maternal death surveillance and response, like the example following on my next slide, which is actually a separate project, but was taken up by E4A and Mama Yay. This work was led by Olivia Bailey and Hilda Chipota, Esther Kayinja, and Tambosi Piri of my Mwana project in Mchinji, Malawi, together with representatives from the Ministry of Health and other partners. This study piloted a community-linked maternal death review process involving both the community and the health facility separately investigating each maternal death. That's the death of a woman during pregnancy, birth, or in the 6 weeks after birth, and then coming together to plan actions to prevent the same thing happening again and following up those actions every 2 months. We found that this approach was able to identify twice as many maternal deaths as health facility maternal death reviews on their own, that more actions were taken at both community and health facility levels to try to prevent similar deaths occurring in the future, and that communities and health facility staff can work together in this process. And we didn't find any adverse effects. The work received attention from policymakers and NGOs in Malawi and was subsequently implemented as part of maternal death surveillance and response in other districts of Malawi. If you want to find out more about this study, please watch my presentation of it to the MDSR network via the YouTube link at the bottom of the slide, or Google CLMDR and my name and select videos. So I'm not going to say too much about this, as Audrey led this work and we'll be doing her inaugural in the autumn, but I wanted to highlight one thing from my role in this amazing work, which resulted in a WHO recommendation on community women's groups for maternal and newborn health. That's that I embarrassingly made a major error in the meta-analysis calculations by doing the meta-analysis on the published odds ratios of each trial rather than the untransformed log odds ratios, which are the raw results from the logistic regression analyses of each trial. So just to say some other words of wisdom here that I think are incredibly important in science. Check your work and admit mistakes and set the record straight. In Malawi, I was also fortunate enough to join an all-star team of researchers from the Malawi National Statistical Office, Johns Hopkins, UCL, LSHTM, University of Malawi, WHO, and Malawi Ministry of Health in working on a case study on how Malawi achieved Millennium Development Goal 4, a 2/3 reduction in child mortality from 1990 to 2015. Malawi went from an estimated 1 in 4 children dying before their 5th birthday in 1990 to 1 in 14 children dying before their 5th birthday in 2013, achieving the Millennium Target 2 years early, prompting the slogan, early adopter, early achiever. We explain why in this now highly cited paper published in Lancet Global Health in early 2016, which I ended up co-leading with Jennifer Bryce and Mercy Kanyuka. The photos here show the celebration event in Lilongwe, which was great and even came with its own cloth. So everyone's wearing it. So coming back to my work on childhood pneumonia, which has been a major focus of my work since 2011, I wanted to briefly talk about our group's work on investigating the added value of pulse oximetry in primary care, in addition to clinical signs, for identifying children who are in need of referral to a higher level of care. Pulse oximetry, shown in the picture here, measures peripheral blood oxygen saturation and identifies those with low blood oxygen saturation, hypoxemia. These patients need oxygen therapy and supportive care. This is work jointly led with Dr. Eric McCollum, and I'd also like to acknowledge the hard work of all our co-authors listed on our papers shown here. In a paper published at the end of 2016, we showed the added value of pulse oximetry in identifying children who require referral. Many of those with hypoxemia would not have been referred otherwise, as they did not have clinical signs that would have resulted in referral. This work caught the interest of the World Health Organization, and we were invited to discuss the findings with an expert group convened by the WHO in Geneva in 2018. Subsequent to that, the WHO funded us to conduct a data linkage study across several of our studies in Malawi, the one on the left, including the PCV13 vaccine study I talked about earlier, to identify whether pulse oximetry use could identify children at risk of mortality who are not identified by clinical signs. We found it did. And in April 2023, we replicated this finding in Bangladesh in a larger, more convincing study published in Lancet Respiratory Medicine. We hope this work will result in stronger recommendations for pulse oximetry use in primary care in high-burden settings and catalyse much-needed investment in pulse oximetry and medical oxygen. Teaching is also a key part of my journey. Although I started teaching on our Masters in Global Health and Development course in London in 2012, which was new at the time, and was appointed as a lecturer in 2013, I first taught colleagues in Malawi and Nepal statistics and epidemiology before that. I have led and co-led modules on perinatal epidemiology and newborn care, maternal health in a global context, and for the last decade, evaluating interventions, a course I designed and started from scratch to fill a clear gap in this area. Teaching is, of course, really important. And I'm glad I've been able to contribute to another 8 masters and 2 intercalated BSc modules across the Institute over the years. I'm also glad to be able to supervise many undergraduate, masters and PhD students, as they're our future. Okay, here's another place beginning with L, Liberia. Since 2015, I've been working firstly on an ESRC-funded project led by Professor Maria Kett on understanding the political and institutional conditions for effective poverty reduction for persons with disabilities in Liberia, and now as a supervisor to Ellie Cole's PhD on people with disabilities during acute health emergencies, including Ebola and COVID-19. There's Ellie in the picture there with our research team for the first project back in 2016. I've also been fortunate to work on a variety of other projects, including the 2015 Lancet Commission on Human Health and Climate Change, led by Anthony Costello, Nick Watts, Hugh Montgomery and Peng Gong, which then also led me to get involved as a supervisor together with Ariana Zecker to Becky Parrish's PhD on climate, crop production and migration in Malawi. and the Refani trials on cash transfers for improving nutrition in Pakistan, Niger, and Somalia, led by Andy Seal and Bridget Fenn, together with Carlos Grijalva Ternod, Vicky Simpson, and many others, shown on the slide. And work on preconception health, led by Judith Stevenson. Working in IGH and UCL has enabled these great collaborations across departments and institutions. So like many epidemiologists, and given my MSc in control of infectious diseases, I also felt compelled to work unfunded on COVID-19, especially in 2020 as the pandemic hit. Like much of my other work highlighted so far, this could also be a whole talk in and of itself, but I've only got one slide. I focused on population-wide testing, tracing, and isolation strategies to try to find a third way between lockdowns and let it rip before vaccines and drugs arrived, with the goal to both reduce mortality directly from COVID and harmful effects on quality of life and well-being via damage to the economy. Amazingly, I was able to co-opt a team of 25 to work on this entirely online and for free, and including many new people I've still never met in person. It was a strange time, those times. And we did have some success in that we spoke to a variety of people connected to policy making in government in the UK, and contributed to getting testing, tracing, and isolation on the agenda when it was initially written off in March 2020, and also not included in high-profile early modelling like that done by Imperial and other groups, which was informing policy at the time. And recently, I was fortunate to work with an all-star cast on the Lancet Nigeria Commission, led by Ibrahim Abubakar. I co-led the Economics and Financing Group with Abina Onwujekwe, and our work highlighting the benefits of tackling the high rates of out-of-pocket payments via a basic health insurance fund got policy traction after the launch of the Commission in Nigeria in 2022. Please check out the Nigeria Commission website here for more details, including an excellent 7-minute video of the work. Okay, so I'll be 43 on Tuesday, and starting in 2005, I reckon I'm about 43% through my career. So I've still got more than half to go and plenty to do ahead of me. This brings me on to the final part of my talk, what I hope to do. First is some work just started, stemming from my evaluating interventions teaching, and together with James Hargreaves, who runs a similar course at LSHTM, and over 30 colleagues across UCL, LSHTM and partners, we're writing a textbook on evaluating public health interventions. This is an exciting project which we hope will also be useful for practitioners and policymakers seeking to understand evaluations of interventions, as well as students on our courses and across the world. The book will be free and open access online. We hope it will be out in the autumn of 2025. Here, and in relation to all of the large and smaller collaborations I've talked about, I'd like to say a few more galaxy brain thoughts. Be curious, be widely collaborative, be open, and be kind. I'm also keen to build on my management experience of the past 5 years to take on leadership roles. Indeed, I've just applied for the IGH Director of Research position a few days ago, though we'll have to see how that goes, given there are, of course, many great professors at IGH who may have also applied. I don't actually know who else has applied. This makes you think of these different career stages. And apologies to whoever coined this, as I can't seem to find the reference now, but learning, doing, managing, directing, reflecting. Although I find myself around here, I think it's also useful to note that you shouldn't stop doing all of the previous things. Indeed, I'm still learning and still doing, as well as managing. And today, at least, I'm also reflecting. With respect to leadership, here's a final set of what I think are galaxy brain thoughts. Facilitate, enable, build capacity, create opportunities and conditions for others to thrive, allow autonomy, have a growth mindset, and invest in the future. So as I mentioned at the beginning, I'm looking forward to the publication and launch of our 9-paper QCN evaluation collection in PLOS Global Public Health in a few months' time. We hope to have accompanying commentaries from the WHO and other stakeholders involved as well, as they look toward the next phase of the Quality of Care Network towards 2030. And our publications are the impact and process evaluations of our inspiring childhood pneumonia research in Lagos and Jigawa states of Nigeria should also be coming out in the first half of this year. And a further 10 or so additional papers looking at vaccination, oxygen delivery, the community facility linkage component of the intervention, COVID-19 in Jigawa, and other connected work should also be coming out in the next year or so, with each paper led by a different member of our amazing team. And our Thanzi La Onse, Thanzi La Mawa health system modelling work also has many papers in the pipeline, again each first authored by different members of our brilliant team, including our main paper describing the whole health system all-disease model, and papers on maternal and newborn health, HIV and TB, health workers, consumables availability, options for prioritisation of healthcare in Malawi, and others around resource use and the economics and financing of healthcare in Malawi. Please expect these throughout this year and the next 2 years. And I'm also just starting work with the Global Fund for AIDS, TB and Malaria in conjunction with the Global Oxygen Alliance on an investment case for scaling up medical oxygen over the next 6 years to 2030. This will be building on work done by Ines Lin via the TLO model for the Lancet Commission on Medical Oxygen Security that should be coming out later this year, and also building on work I did together with Lesong Conte and Obina Onwejekwe for the United Nations Economic Commission for Africa a couple of years ago, which we still hope they will publish at some point. Don't know what happened to that, but it's ready to go. The final thing is going for a new big grant. Since my successful 14th, 15th and 16th grant applications, I have failed to get my 17th, 18th and 19th, 2 very narrowly. So I'm hoping for success with my 20th. As you've heard, I'm interested and keen to work on many things. I may focus my next big application on the economics of reducing the global burden of childhood pneumonia, building on previous work in this area, or around quality of care connected to my health systems work, for example, on context-dependent prioritization of investments to improve quality of care to achieve off-track health-related sustainable development goals. Our ideas, of course, evolve over time, and I'm looking forward to continuing this journey. So that's the end of my talk, but I'd really like to finish by thanking everyone who's shared and contributed to this journey, including all of my amazing research and teaching colleagues, as well as our professional services staff, for all your support in research finances, teaching administration, management and communications, including putting on this event. This is very much a team effort, so please allow me to leave you with this slide and another 30 seconds or so of rolling credits of everyone I want to thank, in order of first name in 2 lists, one from A to K on the left, the other from L to Z on the right. I hope I've included everyone. Thanks also to all of my family and friends. In another event with more time, there will be another list like this of all of you. And thanks to everyone here tonight and watching online. Thank you.
I'm Audrey Post. I'm a professor of global health at UCL, and it's my job to send you merrily onwards to well-deserved drinks and snacks, but not before showing more attractive photos of Tim and a few nice words about him from his UCL friends and colleague. I first met Tim when he was a PhD student working on the extraordinary Maikanda project in Malawi, and he already had a very precocious ability to navigate epidemiology, economics and systems thinking. And that skill remains with him today and is still a hallmark of his work. Welcome back. Importantly, Tim is very much a listening epidemiologist. He's interested in people, relationships, history, and the complexity of contexts. This might explain that when I asked colleagues to share pictures of him in action, I got lots of photos of Tim frowning, looking very serious, and listening attentively in crowded meeting rooms. Sometimes the most radical action you can take is to listen. Tim is also a master at leaning in, but also leaning out. Everyone who works with him knows that he knows just when to give people credit for their efforts and to share in success, but also just when to step in when people need help. And this gift is one of the many reasons why Tim is in such high demand. When I was recruited to LSHTM a few years ago, people said, "Oh, it's great that you're here, but what about Tim Colbourn? Because he's really fantastic." I try not to hold it against him. Tim is a super collaborator, as you've seen from his many papers, and I cannot express things better than our colleagues Dr. Rochelle Burgess and Dr. Nella Geluli in this respect, so I will just quote them. Dr. Burgess described Tim's generosity of spirit, which matches his amazing passion for building better health systems and through that a better world. Dr. Geluli, who has worked with Tim for over a decade, added that he treats everyone with respect and kindness, regardless of their experience or their title. And this is probably one of the many reasons why people like collaborating with him so much. Tim also finds ways to give opportunities to early career researchers, help them get experience, advance in their careers, and all the time supports them and empowers them to rise to new challenges with confidence. Dr. Joe Collins and Dr. Agnese Giuliano, who've also worked with Tim closely, told me about his patience, his ability to encourage and create opportunities for them, but also to be a strong advocate for a good work-life balance, which is so important for early career researchers and indeed for all of us. 2/3 of the photos I got from Tim were photos of the bromance between Tim and Bijoy, legendary friendship which blossomed in Malawi, but is really a collaboration that has spanned over a decade, and I think is a testament to Tim's loyalty and commitment to partnerships. I've also found out about a slightly less cuddly side to Tim. This happened a few years ago when he cordoned me into joining what became a 5-hour leafleting marathon outside a pensions fund office in central London, where we were trying to persuade pension funds managers to divest from fossil fuels. I had no idea that Tim was doing this, and yet here he was spending hours lobbying people. Tim's activism is discreet, but is very steadfast. And in this, he reminds us that as academics, we're not just atomized knowledge economy brokers plowing our ways on Twitter or The Lancet, but we're part of a wider community that still wields a lot of power when we decide to take collective action. Tim has also been a bit louder in his activism recently. During the COVID pandemic, he very much joined the fray, providing epidemiological rigor to heated debates, and he's been largely vindicated in his predictions, as witnessed by another Twitter warrior, our friend and colleague, Professor Christina Pagel, in suggesting that the burden of COVID would really reduce in 2022 and 2023. All this Twitter work takes a lot of time and it takes a toll, and so it's very brave of people who do it. I predict, with a very high degree of precision, that his extraordinary analytical and human skills will serve Tim very well in the remaining 57% of his career. We can't wait to hear what you do next. And the annoying thing is he's just getting started. It's infuriating. Please join me in congratulating Professor Tim Colbourn, and do join us for drinks. Welcome.